Hi, I want to welcome you today. Thank you for joining me on the presentation of the do's and don'ts of talking to people on the autism spectrum. I'm Dr. Sandra Burkhardt. I'm a clinical psychologist here at CRG. Understanding and helping people with autism spectrum disorder and their families has really been a major focus of my professional life. But today I want to start out by welcoming you if you are on the autism spectrum. Let me thank you for joining me today as well. Really everything I've learned about talking to people on the autism spectrum, I've learned from those people with autism spectrum disorder. So I hope the information I'm sharing today will be correct and respectful of your point of view. Just a couple of words about this webinar. Please use the chat feature for any problems that you might experience. Angela's helping us today with the technical support. I believe you can download the PowerPoint slides. If you have questions during the presentation, you can send them, and I'll devote a final portion of the session to answering those questions. And for those of you participating in this webinar for professional continuing education, please know that while the webinar does not provide Category 1 continuing ed units for psychologists or mental health professionals, it can be used as 1 hour of Category 2 continuing ed credit. And all of you attending today will receive a certificate of attendance within a week or so of the presentation. And so now we'll begin talking about the do's and don'ts of talking to people on the autism spectrum. The webinar is really mainly aimed at helping family and friends of persons on the spectrum so that communication can be improved. But this information may also be of interest to professionals who work with individuals on the spectrum. And I'm really trying to gear this towards being practical. So we'll start out with one of our surveys, and this is part of the technical piece here, but we'd like to find out who you are. I believe the poll is open now. So what is your primary role in attending this webinar? Are you a parent of an individual on the autism spectrum, an educator, a direct service provider, or a mental health care professional who works with persons on the autism spectrum? If you'll take a moment to answer, we'll try to get that information, and that'll help me know best who the audience is. There isn't a category there for those of you who might be on the spectrum who decided to join us today. For that, I apologize, but I'll know you're out there. All right, and right now, I believe our results, 9% of the participants are parents of persons on the spectrum, about 60% are educators, and 36% are other mental health care providers. So thank you for that information. Well, today I'll be trying to address several goals. A brief review of DSM-V criteria, looking at autism spectrum disorders, and looking at the concept of social competence. I'm also going to talk briefly about theory of mind and social thinking and how it impacts social behavior, and the special role of negatively expressed emotion as it affects people on the autism spectrum during communications, and then highlight some of the do's and don'ts for communicating. The information in this presentation today, particularly about social competence, is based on a book chapter that I had researched and published, and that reference will be available at the end of the presentation. DSM-V, of course, is the new diagnostic manual, and autism spectrum disorder was a source of some controversy there. But its relevance for today is just its focus on communication. Persistent deficits in social communication and social interaction in multiple contexts is really what is at the core of the diagnostic criteria for autism spectrum disorder. Severity can be based on the social communication impairments as well as the repetitive patterns of behavior, but for today we're going to focus primarily on the social communication characteristics. Those social communication characteristics include deficits in social emotional reciprocity. There can be an abnormal social approach, failure to have back and forth conversation, really reduced sharing of interests, emotions, or affect, or a failure to initiate or respond to social interactions. And so those of you familiar with persons on the autism spectrum know that this can range anywhere from fleeing the room when someone tries to talk to a person on the spectrum to the person directing the conversation strictly to their own interests. DSM-V criteria also talks about deficits in the nonverbal communication. And most commonly we think of that as difficulties with eye contact, sometimes body language, or being able to figure out proximity to other people. Sometimes a lack of gestures or inappropriate gestures. And sometimes there's a total lack of facial expressions. And so sometimes people on the spectrum, whether they're happy, whether they're sad, you can't really tell just by looking at their face. Thirdly, there's deficits in developing relationships. And so adjusting behavior to the current situation, sharing with others or having imagination, and the absence often of interest in other people. So you'll notice that many of the classic things we think about with autism are not really the big emphasis in this diagnostic criteria. The primary emphasis here is communication. I just briefly included the diagnostic criteria of restricted and repetitive patterns of behavior, not really the major emphasis for today's presentation, but worth noting that the kind of motor movements, insistence on sameness, inflexible routines, very narrow range of interests sometimes, and sometimes they're unusual interests, and then reactivity to sensory input, either hyper or hypo-reactivity. Each and any one of these can also be the focus of treatment efforts, and certainly will sometimes affect the person on the autism spectrum's ability to comfortably be around other people. So the DSM-V criteria does require that the symptoms be present from the early developmental period. So it's not something new that just sort of shows up in a particular environment or under a certain social situation. It may not become fully manifest until social demands exceed their capabilities. And it can be masked by learned strategies later in life. And I think this is really important that DSM-V included this in the criteria. Because what it means is that a child may enjoy a very high level of social acceptance and socialization until the social demands start to exceed what they're capable of. And for many high-functioning individuals on the autism spectrum, this happens when they go off to middle school or junior high, high school, or even college. Often they have learned strategies for dealing with things, and it serves them very well. But when they are plunged into a new or unexpected social milieu or set of circumstances, we can rapidly see the symptoms emerge. And of course, these symptoms are causing clinically significant impairments in a variety of settings. DSM-V does make a distinction between individuals with autism spectrum disorder who do or do not have intellectual disabilities and also global developmental delays. And intellectual disability and autism spectrum disorder often are comorbid diagnoses where we find one, we find the other. But it's important to remember that the additional diagnosis of autism spectrum disorder means that the social communication, the ability to interact with other people, is below what would be expected even for that level of development. And I think one of the things that we often see, an example of this, would be individuals with Down syndrome who may have intellectual impairment, but are often quite social, quite engaged with other people, and quite reciprocal in their interests in terms of sharing time with other people. I think it's important also to note, in light of the controversy that we saw about autism spectrum disorder in DSM-V, is that individuals who already had a well-established DSM-IV diagnosis of pervasive developmental disorder or Asperger's should be given the diagnosis of autism spectrum disorder, and then we make note of maybe the severity of the symptoms. This was sort of thrown in as a reassurance to people that they did not lose their eligibility as having this diagnosis. However, as a practical matter, we'll see social service agencies, insurance companies, and other people who fund services asking for a re-diagnosis using the DSM-V criteria. Individuals who strictly have marked deficits in social communication but do not have any of the other symptoms of autism spectrum disorder are often now given the diagnosis of pragmatic language or pragmatic communication disorder. This slide is just developed, I designed it to help identify some of the related diagnoses that we often find with autism spectrum disorder. But the arrow points out that the core of all of these different disorders is communication. And I think that helps us understand how the idea of high functioning, low functioning, some of the titles that we use when we're talking about autism spectrum disorder, we really are often talking about the level of communication deficits that a person has. So many individuals with autism, over there on the right side of the chart, may have intellectual disability, low IQs, low adaptive behaviors, but many individuals on the autism spectrum do not. And so what was previously known as high-functioning autism, Asperger's, nonverbal learning disability is sometimes included there, PDD-NOS, really at its core talks about the degree of communication capability that the individual has. How much support do they need in order to engage in social communication? This also includes a reference to attention deficit disorder. Now, attention deficit disorder is not an autism spectrum disorder. However, in the new DSM-V, attention deficit disorder is a neurodevelopmental disorder. And so it's not going to be completely surprising that we'll see some overlap between ADHD and ASD symptoms. This drawing, the schematic, sort of highlights the fact of something that many of us have probably noticed about people on the spectrum, is that while they may not be very good at paying joint attention, kind of attending to what other people want them to attend to, or attending with other people, they seem to have unlimited attention for their special interests. And so one of the things that we're always looking at to differentiating attention deficit symptoms is whether or not the problem is specifically with joint attention or with our attention in general. Some of the related disorders that we often find with autism spectrum disorder is, of course, anxiety, particularly social anxiety, OCD, Tourette's and other motor disorders. And of course, all of those may be a focus of treatment, even though they are related to the autism spectrum disorder diagnosis. Also, we see mood regulation problems that often look like different aspects of depression or bipolar disorder. It really is up to the provider to decide whether those require additional diagnoses and the focus of treatment. But it's not uncommon to find bits and pieces of all of these different disorders actually being manifested symptoms in a person with high-functioning autism spectrum disorder or even more traditional autism. I do point out, I like to sort of say that communication deficits is at the hub of the problem, and all of those other diagnoses are sort of spokes that come out of that central hub. So we'll understand that addressing and understanding communication deficits often helps to reduce symptoms of many of these other diagnostic categories. All right, we're going to go ahead and have another poll at this particular time, asking you to, I need to take a look at the questions. Asking you which of the following best describes the person with autism spectrum disorder that you're connected or you're concerned about. Those people with autism spectrum disorder that do have language but are without intellectual disability, in other words, they have normal or even above average IQs and cognitive abilities. Persons with ASD who have language and also have intellectual disabilities. They've been measured to have a lower IQ, poor adaptive behavior, or ASD who have not accomplished language at all. So if you'll take a moment to identify some of the persons that you're concerned about, that'll help me also gear my comments moving forward here. Are we ready? Okay. All right. And this indicates that the findings right now of my audience is that about half of you have an individual that you're concerned about who has language and does not have intellectual disability. And of course, that is the group that is frequently referred to as high-functioning autism spectrum. Again, no cognitive disability, and did acquire expressive language. A third of you have an individual who does have language but does have some intellectual disability. And about 10% of people, 12%, have an individual that they're concerned about who has not acquired language. For those of you who have an individual who has not acquired language, some of the communication strategies I'll be talking about may or may not seem completely relevant. I will try and modify as much as possible so that it is also applicable to you. So some of the key vocabulary words that I'll be introducing today have to do with social competence, theory of mind, and social thinking. The automatic mechanism for learning social lessons, it really happens by observation and practice. And it's sort of defined by a social consensus. In other words, people agree that this is the way that you're supposed to act. And when we have children, we have them observe and practice those social lessons. And typically, they begin to acquire those things fairly automatically. And ultimately, that results in what I'm going to be referring to as social competence. So if we said, here's a social lesson about how to eat, we would look at the utensils. But the idea of social consensus becomes really important when we talk about what's the right way to eat. So I use this as an example so that we can see that there is not always an absolute definition of what is the right thing to do, what is the right way to act, how are we supposed to conduct ourselves. That is really up to social consensus. That's up to the people trying to decide what they think is appropriate. So what if the automatic mechanism for learning social lessons through observation and practice in a social environment, what if it's not working? And how many times do we say to the child on autism spectrum, how many times do I have to tell you to be nice? And in their mind, or what they might say is, I was being nice. So we see that there can be a division between social perception, what I think you think, what you think I think, and then what actually happens. If we add to that the outside audience, other people looking over and going, well, who's giving a hug? Who's being nice? You could see that there are many, many people's opinions that have to be considered when we're trying to improve somebody's social skills, social communication, or ability to relate to other people. So what is social competence? Well, it's a combination of social behavior, how I act when I'm in social settings, social skills, or what I would conventionally call manners. Do we know what people are supposed to be saying or doing under certain circumstances? And also social communication. What do I say? In the social arena, members of the social audience, they really serve as judges of the actors and their personal effectiveness. And for people on the autism spectrum, the presence of that social audience can be very overwhelming. The idea that we're being judged by what we say or do, don't say or don't do, how well we do it, can actually serve as a major trigger for social anxiety. Social competence requires the generalization of social skills to the social world for the purpose of achieving interpersonal effectiveness, including friendship and love. So for many parents of persons on the spectrum, teachers, professionals who are trying to teach social skills will find that their major goal is not only getting the individual to be able to acquire social skills and perform them, but also hoping that the audience is going to find those efforts successful, because if the audience finds those successful and interpersonally effective, then we're hoping that we plant the seeds for friendship and liking and even love. A definition that I think helps us understand social competence is successful social functioning at home, school, and in the community, evidenced by independent navigation of needs and wants. Can I handle the social environment such that I get my needs and wants met, and that I can meet the needs and wants of others? ASD and social competence really has to do with some of the key factors that interfere with social competence, and that is individuals on the autism spectrum often have difficulty with sustained attention or sustained conversation. And let me point out, especially for those of you whose children may be nonverbal, that difficulty with joint attention is really at the core of difficulty with sustained conversation. In other words, it's hard for me to be interested in you long enough to even listen to what you have to say or care whether you're listening to what I have to say. Another key feature that interferes with social competence is the lack of awareness of self and others. Some individuals on the autism spectrum are so immersed in their own interests, their own activity, their own self-stimulatory behaviors, that there is practically a lack of awareness that there's anyone else around. Or when other people do intrude into that area of influence, they get agitated or withdraw because they really don't want the intrusion. For many people on the autism spectrum, also reading the emotions of other people is very, very confusing for them, so they may not appear to be socially tuned in because they're reading the situation. Gee, your tone of voice makes me think you're mad at me, or you're bossing me around. You acted like you were my friend, but really now I find out that you were just teasing me. So those things play into the feeling that the individual on the autism spectrum is socially competent. And in many cases, we do find individuals, even when they're capable of language, they don't provide any spontaneous communication. So when they're asked a question or turned to give some kind of a response, they'll do it with prompts, but that they almost never spontaneously try to communicate with other people, or they may have a very small group of people. And if you're a parent of somebody on the autism spectrum, you probably know what I mean, because you'll often find that you're there saying, hey, say hi, tell them what we did on the weekend. What? And so those prompts, well, while we might do that with a young child who we're encouraging them to speak and overcome social anxiety as they talk to other people, sometimes for persons on the spectrum, the person can be in their 20s and their parent or a sibling might be offering those same prompts. In other words, encouraging them to participate in the conversation. I'm not going to read the entire list of social behaviors that were identified that are needed for friendship, but I think if we look at a couple of these, you can see what a tall order it is trying to promote social competence to the level that people can actually achieve friendship when somebody's on the autism spectrum. Some of the ones that I found particularly challenging over the years is getting people on the spectrum to be able to tolerate criticism or to offer compliments to other people. Resolving conflict is often hard for them. There's a lot of what I call right fighting, and that is that because they may be literally correct, they feel that they have to persist in resolving the conflict by dominating the other person's point of view. I also think that body language can interfere sometimes in a friendship because the person may not be able to judge proximity. Accepting the opinions of other people, that is a foundation of social competence and social communication, but it may not literally be accepted by the person on the autism spectrum because for them they see disagreement as someone disliking them. We do want to keep in mind, and I think that this is an important contribution that Lord and Volkmar made some time ago, is that persons with ASD do make strong attachments to others. Autism has primarily, in the old days, been viewed as a disorder of attachment, and in fact, that's typically not found to be true. Although ASD is associated with inadequate social competence, attachment is not the deficit that is responsible for the impaired relationship formation. The primary deficit is social communication, and so I want to reiterate that even when we have a person in our lives with autism spectrum disorder who may not communicate their caring or attachment, very often they are very, very strongly attached, and it's their lack of ability to actually express that in some way that we would understand it that is sort of heartbreaking, but it does not mean the attachment is not actually there. When we try to evaluate a person's capacity for social competence, there's some basic questions, and I'll run through them quickly, but what is that person's capacity for social learning? Do they imitate and learn from others? How developed are their social skills? Do they possess the knowledge of manners and interactions? Have they been taught those things? Is the person able and willing to perform those behaviors and conform to social norms? Sometimes we'll find persons on the autism spectrum actually do have the social skills, but feeling motivated to perform them is often the stumbling block. Can the person produce these applications? Can they spontaneously perform these kinds of social acts in reaction or even informing social situations and responding to situational demands? In other words, are they generalizing the knowledge that they have, the good training that parents and teachers have tried to provide them with, are they actually carrying that out on their own? And to what degree of interpersonal effectiveness is it resulting in the desired social outcome? In other words, do other people find them socially engaging and socially competent? So if we look at this capacity, we can see that treatment goals, goals at home, often have to do with moving the person along this continuum of social competence and capability. So the main goals of this is to improve their ability to read facial cues and nonverbal language, to look at theory of mind and understand that other people have their own thoughts, feelings, and interests, expand the ability to predict emotional responses based on social situations, increase the ability to express emotion in words, and anticipate unexpected actions, reactions, and responses of others. And so how can we work at home on improving social competency? Sometimes sitting down and watching a situation comedy or a favorite show gives us a chance to narrate and in kind of an indirect way autism spectrum disorder in being able to understand situations, read facial cues, talk about the feelings that are being expressed in these shows, especially visual presentations of these themes, is often very helpful for the person on the autism spectrum disorder. Being able to rewind it and look at it again, and you'll often see people on the autism spectrum disorder, with autism spectrum disorder, they'll prefer to watch the same thing over and over again because they're actually detecting new information from it and perhaps trying to expand their repertoire of social responses to things by practicing what other people they see other people doing in these situations. For those of you trying to provide socialization opportunities for people on the autism spectrum, I talk about 3 different kinds of levels of social support. Sheltered socialization is where the adults, mentors, family members, or professionals assist, supervise, and create the social interactions and activities. Supported socialization is where social skills groups, teams, extracurricular activities, camps provide structured opportunities and a sense of belonging. Ultimately, what many of you, especially if your children are approaching adulthood, want is independent socialization, where the person can spontaneously engage in social interactions that are reciprocal and they're based on mutual liking and interests. I do have to point out that as a realistic goal, sheltered and supported socialization tend to be the most common forms of socialization available to people on the autism spectrum. And we need to be mindful of the fact that competitive or independent socialization is often not a completely realistic goal, and the pursuit of that goal can be incredibly stressful for many people on the autism spectrum. So right now we'll take a moment for another poll to sort of see where you are in terms of the level of socialization for the people that you're involved with. What level of socialization do you usually provide for a person with ASD with whom you interact? Sheltered, that is that you're there to provide most of the companionship and interaction. Supported, that you scrutinize where they're going to be and how they will they have proximity to people and experiences that are ASD friendly. Or independent competitive, that basically they're sort of on their own there and trying to make their way. And of course it might be all of the above. Give you a moment to respond. All right. And we'll see now that a number of you did indicate that sheltered socialization is what you provide. Many of you supported. Few of you did identify independent, but certainly all of the above being the most common level of socialization, meaning that probably doing sheltered when you have to, supported when you can, and crossing our fingers and hoping that independent does actually occur. And I think those are excellent goals for people to have in mind and reassure themselves that each and every one of those levels of socialization truly do provide the person with an autism spectrum disorder a rich opportunity to feel socially competent. I'm going to just talk briefly about theory of mind. There is a little video that you can access that does explain it a little bit more in research terms. But theory of mind means that it occurs to me that you might not be thinking or feeling or the same things that I am. And typically, as this little lesson identifies, is that by age 5 or 6, children with neurotypical development realize that somebody else does not know what they know. They realize that they may need to communicate that information to somebody else. And so their language will start to include references for the audience's benefit. I think I know what you need to know. So if a second grader comes home and says, Ms. Smith told me to play outside today, she might also add, Ms. Smith, my gym teacher, making sure that I know which person that I'm referring to. You'll notice that for persons on the autism spectrum, lacking that theory of mind or not having a fully developed one often means that as they relate things that have happened or try to explain events to other people, that the audience, the listener, has to ask many questions or give many prompts in order to get a coherent picture of what's actually happened. By the time individuals on the autism spectrum have been subjected to that for a while, we'll often sometimes find them actually reducing how much they're willing to talk, and so we get sort of this the pat answer of fine, no big deal, I don't know. And it really isn't so much that they don't know as it is, it's hard for me to say. It's difficult for me to string those words together that are going to kind of give you, my listener, what it is that I think you need to do, and too much effort, too tiring, let's skip it. And so we'll often see conversations come to an end when the listener is basically saying, well, why don't you tell me what it is that I need to know? The basis of social thinking is theory of mind, and it does sort of encompass some of the core characteristics of people on the autism spectrum when we think about how we would describe them. The typical social reasoning theory of mind emerges spontaneously and improves in accuracy and efficiency over child development stage. But for people on the autism spectrum, well, thinking, I think you might be upset, is an act of empathy. So even a young child will go, oh, it looks like mom is mad, or and so they're really trying to read the other person's mind and often try to feel the same thing the other person is feeling. Reciprocity, I had a turn, so it's your turn. This basic sense of fairness, so whether it's sharing the toys or handing over the conversation to somebody else, reciprocity becomes a fundamental principle of social thinking and ultimately social competence. Naivete, or being able to read cues of, you know, I know you're not telling me the truth. Maybe you're teasing me, maybe you're lying to me, maybe you're deceiving me. People on the autism spectrum, even those without intellectual impairment, often find it very difficult to kind of reason their way through, well, what might be that other person's motives. And so we often talk about people on the autism spectrum as being naive. And then literalness, that can be taking words literal, like, you know, the old puns that we might hear about, you know, I'm shot today. Well, you know, where's the bullet wound? But it can also mean a literal interpretation of the words versus the tone of voice. So I guess your tone of voice tells me you're joking. And we'll often see conflict in families because families use a lot of levels of social communication, many of which include things like joking and teasing and tricks. And for the child on the autism spectrum, the family member on the autism spectrum, this often leads them to withdraw from the family or feel like family members don't like them. So as we look at social thinking, I like to think of it as a waterfall and a pool of water. The social thinking is up at the top, the headwaters. The feelings are the waterfall. Sometimes it's just a trickle of feelings, and sometimes it's a deluge. And finally, then we look at the social behaviors or the actions, and that can either be a very nice little comfortable pool, or it can be one that's overflowing with disruptive behaviors. So if we think about this model, if the person on the autism spectrum thinks, well, I really need to finish this, he's mean, she's wrong, then I think that it makes sense when we look at their emotions that they're going to start to be upset, angry, or confused. And so then when we look at the behavior that is at the bottom of this hierarchy, we're going to see that tantrums or flight start to make sense. So improving social communication for persons with ASD, sometimes the interactions just don't go as planned. So some suggestions, we do want to provide a calming environment, and the acronym CALM helps us remember what are some of the things that are helpful. Communicate statements that are clear, accurate, and factual. If we're really trying to calm a situation down or get things organized, reducing the amount of social communication and focusing on what I'll call instrumental communication often helps to get things right back on track. Accommodate, provide realistic, proactive, and responsible options and advance notice. This calming does help the person on the autism spectrum focus on controlling their emotions and their behavior. Lead by example. You can reaffirm, we can reassure, affirm, or inspire calm. And finally, model the reactions that you want. What we really don't want to do is escalate the situation. Threats, sarcasm, yelling, teasing, all of those things, while they're perfectly normal and typical forms of social communication, really do not have a good effect on the person in the autism spectrum. I'd like to use the analogy that strawberries are a perfectly fine fruit. Maybe not everybody likes them, but they're perfectly fine. And usually strawberries result in people being somewhat happy. So negatively expressed emotion, teasing, even yelling or whatever else, a coach barking out orders, usually results in pretty effective outcomes. But if we think about that exception to the rule, where even one strawberry, one episode of negatively expressed emotion might result in hives, we can see that for the person on the autism spectrum, one negative interaction with a person, one episode of a teacher screaming or yelling or threatening, may have a very, very strong and long-lasting reaction, an uncomfortable reaction for the person on the spectrum. And I like to use this analogy because I think that none of us would think that the answer for a kid with hives is to feed them more strawberries until they get used to it. And so modifying the amount of negatively expressed emotion that we expose persons on the autism spectrum to is really an excellent antecedent management technique to reduce their discomfort and to keep things from escalating into some of those unwanted behaviors. Because negatively expressed emotion can lead to a flood of bad behavior. And often that's when we see some dangerous and emergency situations develop. So again, improving communication with persons on the spectrum, what we want to do is promote comfort, translating the social situation from neurotypical to autism adjusted, and check for the fit. There's a goodness of fit with the person with the autism spectrum, with certain family members, certain teachers, certain activities. We don't want to confine or confuse or invalidate feelings. We wouldn't want to go on a hike in ballet slippers, walking on point. We'd much rather have a good pair of hiking boots. So what's basically needed is, and many of you are already serving in this role, is to be kind of an ASD tour guide and a translator. The good ASD tour guide and translator is really bilingual. They speak neurotypical and spectrum so that they can take situations and the verbal and nonverbal communication and translate it for the person on the spectrum. They need to plan ahead. They know the trip and they're prepared. That you can anticipate how this birthday party is going to go, how dropping this child off to college is going to go, and it's planned for. And while we always want to encourage these excursions and immersions, go out and do these things, try independent socialization, go for the job interview, go to the birthday party. What we want to remember as a good ASD tour guide and translator is it will not feel very good to be pushed off the cliff for the person on the autism spectrum. So the amount of sheltering, support, and guidance is an important part of maintaining their sense of social competence as well. We want to keep in mind that diversity, disability, and difference are different ways of viewing people. Person-first language is essential these days. We talk about the child with Asperger's, never the autistic person. You can become ambassadors of attitudes, and that is more important than the information that you give. You can give family members or people that you work with or teachers, all sorts of information. But the attitude that you model for other people really does more to provide a ASD-friendly social environment probably than anything else. And right now, neurotypical is the preferred term for persons who do not have ASD. I'd like to point out that in Canada and other parts of the country, the concept of neurodiversity is being promoted by people with high-functioning autism spectrum disorder, and they do not view themselves as having a disorder. They view themselves as being atypical, or they're wired differently, but that there is nothing wrong with them. And so in some respects, they resist and resent attempts to change the way they communicate, the way they act, or the way they pursue their special interests. It will be an interesting new civil rights group as we see the numbers increasing over the decades. I think one way to help shape our attitudes is to think of ASD as a condition. But impaired social communication in many cases is the core of the disability. It makes it, it's what they are unable to do or unable to do easily. What we don't want to be doing is creating the handicap. We don't want to be the person, the classroom teacher, who won't modify communication, thereby handicapping the student with ASD. So the example, cerebral palsy is a condition that creates a disability regarding movement, but it's curves and stares that are actually creating the handicap, the inability to function in the environment. And so as we look at why we want to improve the capabilities of the person with ASD, we should equally be looking at how do we improve the social environments in which people with ASD live their lives. Again, focus on the person rather than the disability. Avoid believing that people with especially autism spectrum disorder somehow are super people, or that they have these overdeveloped gifts. Some do, they are savants, but many do not, and so we don't want to stereotype people on the spectrum. And of course, it's become incredibly politically incorrect to talk about people with autism spectrum disorder as if they have an affliction. I'll just take a moment here to encourage you to ban the word retarded from your vocabulary at all. That has become a political movement on behalf of Americans with disabilities, and so the term now is intellectual disability. Accommodations are things that we do for persons on the autism spectrum so that they can function better and that they feel less handicapped in the environment. Reasonable accommodations are those that are easily implemented, and I think that becomes a legal issue for many people as you look to transition to the workplace, college, out into the community. And what I'm, of course, promoting here is the concept of universal design, and that is accommodations that can benefit everybody with or without disabilities that are easy to do and would make it less of a struggle for people on the autism spectrum. So we want to include people on the autism spectrum. We want to respect their efforts as they have to endure low-interest tasks and high-stress expectations. And we also want to accept their need for supports to adjust to new and unpredictable events. Not see that as something wrong with them, but accept that that is part of the accommodation they need. We don't want to marginalize them. We don't want to focus on their benign, socially awkward communication and behaviors. It's impolite, and there's probably no need to focus on those sometimes. And we don't want to force on them demands for enjoyment and participation, especially if they are showing signs of fatigue or stress. All right, so we're going to do our last poll right now. And this one has to do with kind of a question here. Parents know their son with ASD will only remain calm at a family function for 30 minutes. So which of these is not a reasonable accommodation? Planning to leave after 30 minutes, providing alternative activities for him after 30 minutes, insisting he continue to interact for the entire party. I'll let you place your votes there. And I'm expecting that we'll get a high consensus here. Yes, and I think that we see that 100% of you do realize that some accommodation has to be made. Nobody wants to leave the party. Some people say, well, it's not reasonable to always accommodate the alternative activities, and you may be right some of the time. But I think that we would all agree that insisting he continue to interact for the whole party may be a form of a recipe for disaster there if, in fact, the child starts to show bad behavior that then becomes a conduct problem that has to be addressed. I did mention that much of the material that I've presented here is actually from a research chapter that I had published in 2008, so that's the reference there. Additional references that I used today. A couple of additional resources for you. Here's a website that leads to the extensive amount of information regarding social thinking. I thought it was fun to sort of include an online quiz that is associated with figuring out if the person themselves has autism spectrum disorder, and an example of a website that is designed for persons on the autism spectrum to help them find friends. And I believe that one is actually designed by people on the autism spectrum themselves. I really want to thank you for joining me today. We're going to take some questions now as they come up here. Okay, the first question I see here is, where can we download the PowerPoint presentation? And it's in the handout section. And in your menu there, the handout section should have the PowerPoint presentation. If not, please let our business office know and they'll be able to direct you to that. Any other questions? All right, well, I'll be wrapping up. If there are any other questions, you can certainly feel free to email me. I want to thank you for joining me today, and this webinar will be available in a YouTube format in the future on the CRG website. We'd encourage you to sign up for the CRG newsletters and announcements by registering at the Constant Contact link on our website, which is www.childrensresourcegroup.com. And I'll invite you to join us for another webinar by Dr. David Parker on Wednesday, June 29th at noon, to discover the top 10 strategies for making a smooth transition to college. You can register by calling CRG's front office at 317-575-9111. Again, I want to thank you today, and my email address is at Children's Resource Group. I'd be glad to be in touch in the future. Thank you very much.